Okay, good afternoon everyone. My name's Chris Oxenford from the Laboratory Strengthening and Biorisk Management team in WHO headquarters, although physically located in the French city of Lyon. And I'm here just to give a perspective from the WHO perspective of how we address certain zoonotic diseases. And we're all, in the health sector, we all think, oh, animals, they're all sort of terribly unclean and all that sort of thing, and particularly if they're armed, they're even more of a threat. So what we'll do, all right, there we go. Okay, so just to make a start. Even the most urbanised countries are at risk of zoonotic diseases. Just last year, we had a large outbreak of Middle Eastern respiratory syndrome coronavirus in the Republic of Korea, which is one of the most urbanised countries in the world. So just for people to remember that even though we do live in, most of us live in cities, the risks from potentially zoonotic diseases are ever present. And air travel now means that these diseases can spread virtually around the world within days. And so when we come to look at these diseases, how are we going to diagnose them in the initial cases, how are we going to deal with them, it's really important to have that understanding of travel history. And I think people may remember back to Ebola when it got in, a few cases occurred in the US last year as well. The problem was that the travel history wasn't identified as a potential risk factor very early on. So as we're all aware, nearly 2/3 of the emerging infectious diseases that we've been faced with in the recent decades have been zoonotic, and the vast majority of these actually come from wildlife. And this situation is only going to continue because there's now increased contact between humans and wildlife. And it's happening for a variety of reasons, particularly in places like Africa and certain parts of Asia, where we're seeing increasing movement of people into forests as part of extractive industries to establish agriculture because of increased demand for arable land. Mining and logging are now huge businesses in many African countries, and also we have civil disruptions, warfare, movement of large numbers of people. And so we're seeing more and more people moving into areas where they haven't been previously, and so they're encountering some of the pathogens that are circulating in those areas. So the way one way to think about these things is to think about, okay, well, which are the ones that can easily spread between animals and people, but human-to-human transmission, which is what's going to cause us the biggest problems, is not common. And there we think about H5N1, which we were discussing this morning, and Middle Eastern respiratory syndrome coronavirus. In the Middle East, in Korea, we saw a completely different situation where we saw mostly all human-to-human transmission. And then also we have zoonotic pathogens where there is relatively easy transmission between humans, and Ebola is the thing that we can remember there, and also the pandemic from 2009. And also we have zoonotic diseases where there is no or virtually no transmission between humans, and rabies is the prime case there. So I thought we might just spend a little bit of time going through and looking at each of those scenarios and see what are some of the impacts on control. And so if we just start with rabies, I'm sure you're all terribly familiar with it here. As we know now, it occurs in 150 countries, and the vast majority of cases are in Africa and Asia, and most of those are the results of dog bites. In the Americas now, bats are a significant cause, but for most of the world, it's dog bites. And annually, there's at least 20,000 deaths. I mean, these things can be terribly underreported because many cases occur in remote rural settings, and so these diseases, they never get onto a database. So the actual numbers of deaths is probably higher than that. And we're looking at more than 15 million people being vaccinated following dog bites annually. And if you can imagine what the impact of that is from an economic perspective, it's really significant. I mean, you're looking at $40 to $50 for a post-exposure prophylaxis. And for poor people living in village settings, that's an unimaginably large amount of money. So it's really has an enormous impact. So what do we know about rabies? Incubation period, 1 to 3 months, but it can vary from a week to a year and even longer. I mean, we hear these stories of people who have no exposure to rabies coming down with the disease up to a decade after their exposure. Initially, the symptoms, pain, usually at the site, and then we get, as the virus migrates up through the central nervous system, we get progression to the 2 types of disease that we see in humans. One is called furious rabies, and the other one is called paralytic. And the furious one is the one that everybody knows about, with people running around frothing at the mouth and fear of water and death happening fairly quickly, usually within a few days. Paralytic form is much slower in its onset and its progression, but the end result is still the same, death. And case fatality rate is, once symptoms have appeared, is nearly 100%. There's a few people who have survived with certain treatments, but it's virtually 100%. And as I mentioned, post-exposure prophylaxis, $40 to $50, huge amount of money for a lot of people in the developing world. And the other thing, of course, is that you're treating an individual, and that doesn't stop the rabid dog from going around and biting other people. So control-wise, the most effective thing to do is to prevent the dogs with which humans come into contact, i.e. mostly domestic dogs, from being infected. And so that means vaccination. But the question, of course, is who pays. So the control measure, we know that this is effective, we know that it works. We also know that if vaccination campaigns are free, people are much more likely to take them up. And if you say to someone, okay, it's going to cost you a couple of dollars, $3, $4 or whatever, to vaccinate your dog, if that's a day's income or a couple of days' income for a farmer, he's probably going to say, nah, I'll pass on that. And we know that it takes about, if you vaccinate about 70% of the dogs that are in an area, it's possible to virtually eliminate transmission of rabies in that area. So it can be done. We know how to do it. It's just a matter of finding the political will and the money to actually make it happen. And WHO has been working with FAO and OIE and the Global Alliance for Rabies Control to raise awareness and to get commitments to overcoming this disease. Because it has been eliminated in dog rabies, has been eliminated in many Latin American countries. So we know it can be done. We know it works. And so it's just a matter of getting that ongoing political commitment to ensure that we can actually get this under control. But it can be done. Just then to move on to Middle Eastern Respiratory Syndrome coronavirus. This is usually known as MERSCoV, again, viral respiratory disease caused by a novel coronavirus. It appeared just a few years ago, just in 2012. It had never been, we'd never had any idea that this was floating around there. And as we know, coronaviruses are a large group of viruses ranging from very mild symptoms related to the common cold right up to severe acute respiratory syndrome, SARS, which we saw more than 10 years ago now. And the impact of that, it was actually probably in dollar terms the most significant epidemic that there has ever been in terms of money, in how it disrupted the global economy. So strictly from a purely financial point of view, not talking about public health or disease-specific impact, SARS was probably the most expensive disease that there has ever been. Coronavirus, in Middle Eastern coronavirus, typically it starts off with fever and cough, shortness of breath, and then often they go on to develop pneumonia, although that's not always present. Gastrointestinal symptoms and also kidney disease has been reported quite often. At the moment, the case fatality rate is around 36%. Earlier times it was higher because it was really only the severely ill people that were being identified. But now there's a lot of surveillance going on, so more people are being tested, and so as we get a better idea on the spectrum of disease, because some people don't get particularly ill, whereas other people get very sick, the case fatality rate has come down quite a bit. And the actual transmission of the disease it's a combination. So we're seeing many cases of human-to-human transmission, but they're very circumscribed. They're mostly happening in healthcare facilities. Most of what we tend to see is that people are being exposed most likely to camels. But the exact route of transmission is not well understood, because in these Middle Eastern countries, lots of people have a lot of exposures to camels. And how is it that some people get sick and many other people don't? Means that the route of transmission or the mode of transmission is not precisely understood. As I mentioned, the virus does not pass easily from person to person unless there's really close, intense contact. And so the situation that we most commonly see is in nursing staff in healthcare facilities. We've looked at, there's been a lot of studies being done on the presence or the prevalence of the virus in humans and particularly in camels. And the prevalence rates in camels are just astronomical. They're almost 100% in some herds that have been tested. And again, but there's no easy relationship with disease in the humans that are associated with those camels. And so there's still an awful lot about this disease that we don't understand. People who are exposed or have a lot of contact with camels, they tend to have higher prevalence of antibodies. But, as I said, it is certainly not a clear picture as yet. So to date, WHO has been informed of 1,644, it might have gone up in the last day or so, confirmed cases with around 590 deaths. And there appear to be two groups that we're dealing with. These are the primary cases which aren't linked to other cases, and these tend to be males. They tend to be older, and they tend to have comorbidities, diabetes, cancer, a whole range of things. And they're the people who tend to get severe disease. So they're the people who first came to our attention a couple of years ago. We started seeing this disease, and they often have exposure to camels. So many people, it's part of the culture in the Arabian Peninsula to have a few camels in the farm, out of town, and so you go and spend a bit of time with them, and that's just part of the culture of the region. But the interesting thing is that the owners, who are these older males with the comorbidities, they tend to get sick, but the guys who are actually working with the camels on an everyday basis, much less so. Either they never get sick, or if they do, we do detect antibodies in them, or they become seroconverted, they've either never been sick or just had a mild, a bit of a cold, something like that. So they're the primary cases with no other exposure to human cases. And then we have the secondary cases. And so these are the outbreaks that we've seen, and we've seen a few of them now. And the Korean example is the most extreme, where most transmission occurred in healthcare facilities. But most of the people who are infected, they tend to be younger, they tend to be female, just because of the nursing staff. They tend to have no other comorbidities, and they tend to get mild disease, or they're completely asymptomatic, and they're just picked up on screening. So they're either detected by PCR or some other molecular test, or they're found to have antibodies. So these are the two situations that we're tending to see. And the control measures are obviously quite different for the two groups. And so there's just a map and a little chart down the bottom there showing the epicurve for this disease, and you see it. We've had a couple of really big outbreaks in Saudi Arabia in the light purple one on the right there. I don't know if you can see it clearly. That's the situation in Korea. So prevention is dependent on the type of your possible exposure. If you're an elderly male with comorbidities who owns a few camels, you probably should be quite careful. So don't go around drinking raw camel milk or camel urine, which I don't know why you'd want to, or eating meat that has not been properly cooked. So just the normal things that you would do in a situation like that. And if you're one of the people who are at risk of secondary transmission, infection prevention and control in healthcare facilities is absolutely crucial. So promoting that has been a key message. And unfortunately, one of the things that we've seen is that there's an outbreak in a healthcare facility, the investigators go in, they do, they carefully look around and they see where things have broken down, and they make the recommendations and the outbreak comes under control. But then it's possible subsequently that the situation repeats itself, that the message isn't sticking, it's not sort of lasting, and so we're tending to see repeated outbreaks in some facilities. And of course, as I'm sure the Koreans would remind you, people who are symptomatic should not travel. And this is something that's true of most diseases actually, but a number of cases, of situations where people have travelled to other countries while symptomatic, and this just causes an enormous amount of problems. And in fact, the index case, I think it was the index case from the Korean outbreak, or maybe the second case, travelled while he was sick to China. And fortunately, it never went any further. But he was advised not to do this, and he didn't tell anyone that he was going to do it. And so that is a big contributor. And the last one I wanted to mention was Ebola. And I think the memories of the outbreak in West Africa are still fresh in everybody's minds. And as we know, Ebola is an acute serious illness which is often fatal if untreated. And we've known about this disease for about 40 years now. There are a couple of outbreaks in Eastern Africa. And certainly the outbreak in the West Africa, which first came to our attention in 2014, it's been the biggest and most complicated complex that we've yet encountered. But one of the things was that this is the first time that it's occurred in West Africa, and so nobody was really looking for it. And so by the time people realised what had going on, it had got away from its fairly sort of remote forested environment where it started up, and it had crossed one or two international borders, and it also got into some big cities. And so that was a situation which hadn't happened in Eastern Africa previously. The outbreaks again had started in small rural settings, but it had been caught before people had started travelling to big cities. And so we've never previously had that situation with large cities being involved in outbreaks. We think it comes from bats. In fact, there's a reasonable amount of evidence now that bats are the sort of natural host of this virus. And it's introduced into human populations through close contact with the blood and secretions, etc., of infected animals. And these can be chimpanzees and other monkeys, gorillas, fruit bats, antelope and porcupines. So people are going out into the forest, they're finding sick or dead animals, and they're bringing them back into their homes, and they're using them as food. Human-to-human transmission occurs through direct contact. So the virus gets through broken skin or through mucous membranes. So usually what happens is that when you're infected, you're not really infectious until after you start to become symptomatic. And as your symptoms progress and you become more and more sick, the virus load in your body becomes higher and higher, and at the time of death, you are very, very infectious. And so you have these situations where people who have been in bed and all that sort of thing, so all their bedding and all their other things that they've come into contact with are highly infectious. So because of that, you know, healthcare workers have been frequent victims of this disease, and it was really quite surprising, the number, even after we knew what was going on, the appropriate measures, personal protective measures had been put in place, healthcare workers were still being infected. And even with the, you know, you can watch someone putting on their PPE and taking it off, and even the most experienced person, you can spot individual little errors that they've made, and you can say, okay, you were at risk there, or you did something there. And particularly, this outbreak was happening in very hot countries, and I don't know if you can imagine seeing people done up in those white suits. If you've got that on for more than half an hour or so, your goggles have started to fog up, and it's hard to see. You're overheating quite significantly, and so it's actually it's very difficult to keep that on for a lengthy period of time. And then you've got to go through this very rigorous procedure to take it all off and make sure that you're not contaminating yourself. So the people who were part of those burial teams, they did the most unenviable job, but they generally did it very well. And actually, because unsafe burials was one of the major causes of spreading disease, because there are a number of cultural practices that people would have in this part of the world where with a body, like someone's died, is that you wash it and you get very close to it. And so that's that sort of thing was one of the main drivers of spreading in infections then. And in a number of countries, when they were trying to control this, the burials was actually a job that was given to the military. And so all the burials were actually organised by the army. And so when they do things, they tend to be quite serious about it. So that was one of the key factors in ending transmission. So again, control is focusing on what are the potential risks of infection, where are you likely to be exposed. So if you're out in the forest and you're having contact with wildlife, obviously the control measure is to avoid the sick ones. I mean, because they're the animals that are most likely that have been infected, so you avoid those. For reducing the risk of human-to-human transmission, hand washing, can't overemphasise it. And there were little stations like this actually in front of virtually every public building. Every shop, every hotel, every office block would have a bucket like that where you'd wash your hand. It was chlorine. It was chlorine, and it would again, that played an important role. And also, there's the risk of sexual transmission that we've heard a bit about as well, and so that's something else to consider. And one of the things that really did play a role in stopping the outbreak was the safe burials and monitoring and separating sick people. Because, as I said, if you're not sick, if you're not symptomatic, you're not infectious. So the idea is that as soon as you become symptomatic, so usually the measure of having symptoms was having fever, and so as soon as that was done, it was important to isolate those people until a laboratory diagnosis could be done. And in the healthcare settings, the most important thing was having the appropriate personal protective equipment, and when you were doing injections or collecting specimens, to make sure that that was done using safe procedures. And that table just shows you some of the countries that where Ebola cases were diagnosed. And fortunately, we haven't had any cases for a couple of months now, so we're hoping it's all finished. So how does WHO deal with these sorts of situations? And the chief mechanism of doing this is a mechanism called the International Health Regulations. And these came into force. They were adopted in 2005 and they came into force in 2007. And they cover all threats to global public health, and these can either be biological, chemical or radionuclear. And the requirement is that countries have the capacity to detect and report on what's called a public health emergency of international concern. So they have to have the ability to detect one of these events, and they're also obliged to report it to WHO. And they're also required to respond to requests. Because one of the things that will sometimes happen is that country A will ring up WHO and say, oh, we think country B next door has some horrible disease going on. And if that information is credible, WHO will then contact country B and say, okay, do you have this disease? And they're actually required to provide information there. And then WHO can then make temporary recommendations on how to control this event, with the proviso that it doesn't inconvenience too much travel and trade. Public health emergencies of international concern, there's only been a few of them. Most of them have been in the last year or so. The most recent one was about 2 or 3 weeks ago, when the Zika virus associated or potentially associated microcephaly was declared a public health emergency of international concern. And so when that happens, WHO makes a series of recommendations, and countries are supposed to follow them or inform WHO if they're not, and then that situation is then reviewed on a regular basis. And just to finish up, I mean, we've talked a little bit about some dangerous animals, but this is the most dangerous animal regarding human health out there. They are responsible for more disease and death than any of the other ones that we've considered. And I said it's not just viral diseases, but it's parasites like malaria. So these guys are the public enemy number one. And as we're aware, many vector-borne diseases are also zoonotic. And many of the human vector-borne or mosquito-borne viruses, they exist as a cycle in the forest. So they have a sylvatic cycle, and then they go through secondary cycles and bridging vectors, which brings them closer to humans and to domestic animals. But from the virus's perspective, infecting a human is not much of a big deal, because for most human diseases that are caused by mosquito-borne viruses, the humans are a dead-end host. You just don't get enough viral replication in the blood for then a mosquito biting that human to then become infectious. There are a couple of exceptions, principally yellow fever and dengue. And just to give you an example, this is the cycle for dengue. And you have sort of the sylvatic cycle on the left there between primates and some tree-dwelling Aedes mosquitoes, and then you can get spread down through people going into the forest, bringing it back into their villages, and then you can get movement to the cities. And dengue is one of those diseases where a cycle just amongst humans is possible. And so, I said dengue and yellow fever are the main ones, where human-to-human transmission via the mosquitoes, of course, is a major feature of the disease. And it looks like Zika virus is probably in this category now as well. So just to mention, Zika virus, as you're probably aware, it was first identified in Uganda in 1947, in monkeys that were being monitored as part of looking at what's happening with yellow fever. There was another 4 or 5 years before human cases or human infection in human was actually identified. And since then, the first really big outbreak that we saw in humans was in the Pacific Islands in about 2007. And since then, obviously, there was a big outbreak in French Polynesia in 2013, and now, of course, we've got what's happening in Latin America. And most infections are either asymptomatic or mild, and so we've known about this virus for nearly 60 years, but nobody was terribly worried about it for most of that time. But as I said, during the outbreaks in French Polynesia and now with what's happening in America, people started to become aware of neurological symptoms that were occurring in these people, and particularly in French Polynesia it was talking about Guillain-Barré syndrome, and now in Brazil there's this risk of microcephaly. And as time has progressed, and information is now accumulating excuse me, very rapidly, and the evidence that there is an association between Zika virus and microcephaly and Guillain-Barré syndrome is growing almost on a daily basis. There are more and more reports coming through that this is a real association. Obviously, there's still definitive studies to be done to confirm this, but the evidence is mounting all the time. And what is urgently needed now is, in addition to these studies to confirm this association, is the development of new diagnostics and therapeutics to make it easier to confirm a diagnosis here. Diagnosing flaviviruses can be quite challenging, particularly on the serology side when you're looking at antibodies, because there's a lot of cross-reactivity between antibodies from the different flaviviruses, and particularly in Latin America you've got dengue, West Nile virus is circulating. In addition, a lot of people have been vaccinated for yellow fever. So there's a lot of flavivirus serology going on in these people. And so actually interpreting that can be quite challenging. And of course, if this is a real association and we want to try and control this, well then developing vaccines is going to be the big priority in the coming months and years. And so that was all I had to say, and that's about the only picture I could ever find which had a camel, a monkey and a dog in it at the once. So that's what that's there for. Thank you.